An 8-year-old boy comes to the physician with a history of abdominal fullness. Physical examination finds hepatosplenomegaly. Laboratory studies show hemoglobin 11 grams per deciliter, normal range 13.5 to 17.5, hematocrit 33%, normal range 41 to 53, leukocytes 20,000 per millimeter cube, normal range 4,500 to 11,000, neutrophils segmented 30%, bands 7%, lymphocytes 58%, monocytes 3%, eosinophils 2%, basophils 0%. Platelets are 80,000 per cc, normal range 150,000 to 400,000. Further testing reveals a large amount of double negative T lymphocytes in the blood and the inability to induce apoptosis on lymphocytes ex vivo. Which of the following is likely also found in this patient? Choice A, translocation of chromosome 12 and 21, T1221. Choice B, absence of MHC type 2 on antigen-presenting cells. Choice C, elevated levels of Fas ligand in the blood. Choice D, large amounts of IL-12 and interferon gamma. Or choice E, increase in cytochrome C release within lymphocytes. I'll wait 5 seconds and then answer the question. This is a similar question to one found on the MBME, and I didn't actually play around with the diagnosis too much, which in this case is ALPS, autoimmune lymphoproliferative syndrome. And the reason I didn't play around with it is because ALPS is actually not some super important diagnosis you need to know. You can have it in the back of your mind, but more importantly, in both this question and the MBME questions where this will typically show up, they're going to be testing you about something far more fundamental than that, which is about the apoptotic pathway. And I've talked about this before in the past, but let's not get ahead of ourselves. I'll just explain ALPS real quick. In ALPS, you have a defect in what's called Fas, which is CD95. Fas is used in one of the extrinsic apoptotic pathways, so as a result, lymphocytes will fail in achieving apoptosis. And we know how important that is because obviously we think about T cells. When they go to the thymus, they have to go through both negative and positive selection. A huge part of that is inducing apoptosis on these cells. So if you're missing something that causes apoptosis, then you can have this situation where the lymphocytes just kind of get released without care into your blood. So you have a lymphocytosis, which is what you see in this patient. And in ALPS specifically, you typically see these double negative lymphocytes, which normally wouldn't survive the T cell maturation process. And like I said, it's because of a defect in the Fas receptor, essentially. And in order to activate Fas normally, you need Fas ligand. And because in these patients you have a defect in Fas, what will end up happening is that you will actually have elevated levels of Fas ligand in the blood. So choice C is the correct answer. Now, like I said, I don't think it's important for you to walk away from this question having some kind of intimate knowledge about ALPS. I mean, it is something that's kind of interesting. You can learn about it. But more fundamentally, you need to understand apoptotic pathways. And I've talked about this in other questions before. And this is one of those kind of basic biochemistry things that you have to know about apoptosis. So you need to know that there's an intrinsic and extrinsic pathway. In intrinsic apoptosis, which occurs because of cell injury or DNA damage, or it occurs naturally as a result of embryogenesis, because of course, as a natural part of the body shape and body planning during embryogenesis, we need to get rid of certain cells. So anyway, the intrinsic pathways, two things you want to know are the BCL2 anti-apoptotic molecule and the pro-apoptotic molecule, BAX. These are factors that are kind of in balance to control cytochrome C, which itself will go downstream and activate a bunch of caspases, which can cause apoptosis. And they've asked about a lot of these before on various questions. They might ask about, some kind of apoptotic molecule or a molecule going through apoptosis. And you might say, like, what's going on in this cell? What's elevated? And the answer might just be caspases. The only other important takeaway from the intrinsic pathway is the BCL2. This is very buzzy when you're talking about follicular lymphoma, which is the most common indolent non-Hodgkin lymphoma. Usually presents as like a neck mass or something. And they might end up asking you, oh, what's overexpressed in follicular lymphoma? And the answer will just be BCL2. Anyway, that's not important in this question, right? Because this question is actually about an extrinsic apoptosis. Extrinsic apoptosis, as the name implies, it's some kind of outside death signal attaching to a cell or signaling it and telling it, you gotta go through suicide. And of course, related to this question is that Fas ligand can bind to Fas receptor / CD95, which can trigger apoptosis. Tumor necrosis factor can also lead to apoptosis as well as necrosis. And killer CD8 T cells, we always hear about it. They can cause apoptosis because when they want to kill a cell, they will disrupt cell membranes by releasing perforin, and then it will release granzyme B, which will also go and directly activate caspases, causing apoptosis. So, like I said, the reason I said that ALPS isn't some super important thing you need to know is because usually if they're going to give you an ALPS question, they're going to say something about Fas receptor or Fas ligand, and then they'll just ask you something about apoptosis, because that's the real testing point. Do you understand how apoptosis works? So let's take a look at some of these other answer choices, because that was a little bit mean with some of these answer choices, especially choice A, 1221 translocation. Obviously, this is ALL, acute lymphocytic leukemia, which can look kind of similar to ALPS on a surface examination, because similarly, you might also have a lymphocytosis and cytopenias. Some of you might have looked at this question and saw a lymphocytosis in a child and then instantly picked ALL as your answer, but ALL questions usually are not going to ask you about apoptosis because that's not the primary problem in ALL, right? They're going to give you a lot of different things. They're going to give you TDT positivity, clusters of differentiation like CD10. It usually presents with fevers and recurrent infections. They might have some bleeding. And maybe some of you who are very well read will tell me that, well, comprehensively, ALPS can present kind of similar to ALL. But on USMLE, they're probably not going to give you an ALL question and give you like some really convoluted question about apoptosis. That would be really, really mean. And for those of you who are wondering, and this is just a general rule that's good to know, in a lot of these conditions where you have a huge leukocytosis or lymphocytosis, you will also unintuitively get recurrent infections a lot of the time. So some people, when they first learn about that, they get a bit confused because it's like, oh, I have so many white blood cells. Why would I get more infections? It's because these diseased white blood cells from a cancer or like an ALPS, some kind of mutation, they are not really functional white blood cells that work properly. So kind of paradoxically, you will simultaneously have both autoimmune symptoms as well as immunocompromised symptoms. Anyway, wrapping this up, ALL and ALPS, they just have totally different presentations on USMLE, so it's very unlikely they're going to give you a question where they try to make you confused between the two. Choice B, absence of MHC type 2 on antigen-presenting cells. This is Bair lymphocyte syndrome, not a super high-yield condition, but you should understand, like, intuitively that Bair lymphocyte syndrome results from MHC type 2 dysfunction, because you should understand the basic immunology of what MHC type 2 actually does in the body. It's what the cells use to present to CD4 T cells. So if I'm lacking in MHC type 2, then I can't activate CD4 T cells, and therefore that will cause a severe immunocompromised status. And in fact, Bair lymphocyte syndrome is a form of SCID. So typically, if a kid had Bair lymphocyte syndrome, they would probably present even earlier than this, and they would have recurrent infections of all kinds. They would be really sick. Choice D, large amounts of IL-12 and interferon gamma. This is a description of T helper 1 cells and macrophages kind of being in this cycle where IL-12, which is produced by macrophages, will induce T cells and NK cells to produce interferon gamma, and then interferon gamma will kind of come back and amplify the process because interferon gamma will then encourage macrophages to secrete even more IL-12, which will make T cells secrete even more interferon gamma, and then it kind of goes in a cycle. And this is important, especially for granuloma formation. So oftentimes when you get questions about granulomas forming, especially in stuff like TB, they might ask you about certain cytokines, and you got to be thinking of IL-12 and interferon gamma. Anyway, it's just unrelated here, right? Choice E, increase in cytochrome C released within lymphocytes. As we discussed earlier when we were going through different kinds of apoptosis, this is describing intrinsic apoptosis, right? Mitochondria are kind of kept in check by BCL2 and BAX genes. And if a cell needs to undergo apoptosis, the mitochondria will release cytochrome C, which will activate caspases downstream and lead to apoptosis. But as we mentioned with this patient, he has lymphoproliferative syndrome, ALPS, which is extrinsic apoptosis, not related. So your main takeaway from this question is maybe you can know about ALPS, that can be helpful, but it's more important that you understand how apoptosis works because that's more broadly applicable across different questions. I hope you found this video helpful. I'll see you in the next one.